Hello everyone, this is Edmialem. I'm emergency and critical care nurse. We are going to talk about approach of traumatically injured patients today. As you see, the approach is through the primary and secondary survey. So now we are going to discuss about the primary survey. The primary survey is, it's not only the assessment, it includes intervention when the assessment or the findings occur. So the main objective of this video is, after the end of this discussion, the paramedics will be able to rapidly identify and manage the actual and potentially life-threatening condition of the patient. So primary survey is the initial assessment and management of trauma patient. It's conducted to detect the and treat actual or imminent life-threatening condition and the complication of injury or trauma. It uses systemic approach by using ABCDE approaches. A stands for airway and C-spine protection, followed by breathing and ventilation, then circulation. After that, the disability, and E stands for exposure. Let's see each by one by. Airway and C-spine protection is a condition that compromises the delivery of oxygen to the body, or that compromises the passage of air through the lung or through the airway, becomes life-threatening condition, and it should be managed immediately after identifying that condition. So if the patient is responsive, so we have to assess for ability to speak. If the patient is able to speak, so he's fine. But we have to assess for other signs of respiratory distress or airway obstruction, like stridors, slowing, and gargling. So these are some methods of opening the airway and making or maintaining the patency of the airway. This one is the upper one is head tilt and chain lift maneuver, which is not applied for traumatic patient because it moves the cervical spine, so it further injured the C-spine. So we always use this one method. This one is modifiable jaw thrust maneuver. It protects the C-spine. It's not moving the C-spine, so it prevents further injury on the C-spine. So after applying jaw thrust, we are using adjuvants like airways through the through the oropharyngeal or nasopharyngeal airway. We can apply to maintain the patency of the airways. And we can use, if there is any visible secretion, we can apply large bore suctioning. After opening the airway, then we have to proceed to the assessment of breathing and ventilation, and immediately treat if there is any breathing abnormality. So during breathing assessment, we have to discover potentially or actually life-threatening condition, which includes the patient may be develop cyanosis. It is a late sign of hypoxia. We have to assess for respiratory distress with dyspnea or hypoxia. We have to assess for asymmetrical chest movement, which indicates flail chest. We have to assess the chest injury for tension pneumothorax, flail segment, and open chest wound, which is the actual life-threatening condition during primary survey. And if there is any tracheal division or distended neck veins, which suggests tension pneumothorax, or sometimes if there is any distended neck vein with hypotension, it indicates cardiac tamp node. So we have to assess and immediately treat the patients. So if we have to, we are identifying the tension pneumothorax, we have to manage through the chest decompression like this. This one is, as you see, there is a needle inserted to the chest directly to the below the second intercostal space. So it decompresses the oxygen, the tension pneumothorax, so it alleviates the life-threatening condition which occur during trauma by applying the needle. The other one, there is a circulation. As you see, the massive hemorrhage from the traumatic area leads to hypovolemia to a patient. So after excluding tension pneumothorax, because tension pneumothorax can cause hypotension, after excluding it, we have to consider hypovolemia due to massive bleeding internally or externally. So the internal bleeding mainly, which is occurred and can cause hypovolemia, is internal bleeding in the chest, internal bleeding in retroperitoneum or abdomen, or bleeding in the pelvis and long bones suggests or can cause severe shock or hypovolemia. And during circulation, we have to assess for pulse rate, blood pressure, and capillary refill. It suggests the status of the circulation of the patient. If the pulse is palpable and strong, it suggests there is no internal bleeding or there is no shock. If the capillary filling time is greater than 2 seconds, it suggests the compromisation of the cardiovascular function. So circulatory management should be following these three things. We have to control hemorrhage because the hemorrhage can cause hypovolemia or shock. So we have to identify first the internal and external bleeding. Then we have to manage it accordingly. If the bleeding site is external, we have to apply direct pressure. We have to elevate the injured area. Then if it's not controlled through the mentioned methods, we have to apply tourniquet carefully. If the bleeding is internal, it should be managed immediately with surgical management or repair. And after controlling of the hemorrhage, we have to restore the lost blood or the lost volume through the crystalline fluid or through the blood transfusion. After administration of fluid or after administration of blood, we have to reassess the patient about the restoration of his blood volume. The fourth one is disability, which is focused on neurological assessment. The rapid neurological examination done for the level of to assess the level of consciousness through the AVPU during emergency condition. AVPU is to assess the level of consciousness. A stands for alert. V stands for the patient's responding when we ask the patient's name and his response for voice. P responds. P represents when we are applying pain for the patient. When he responds, it's responsible for pain. And U stands for unresponsive. If the patient is unresponsive for voice, unresponsive for pain, it indicates the patient's level of consciousness is decreased. And we have to assess the pupillary size and reaction. If the pupillary size is unequal or unreactive, it suggests the brain becomes hypoxic. And if there is any stroke, it suggests the pupillary size is unequal and unreactive. And we have to assess for localized sign. Finally, the E stands for exposure. We have to remove the patient's clothes so that we can easily observe and easily visible if there is any injury in the back or in any area which is closed by his own. So we have to examine for bullet wounds, for stab wounds, or hidden fracture from the back or in the behind the sleep area, and we have to assess for large bruising and hematoma formation. So ideally, the exposure is preferably done by paramedics with the same gender for privacy issue. Then after visual inspection, we have to appropriately cover the patients for privacy and to prevent hypothermia. Finally, during primary assessment and intervention, there is advances we can use during primary assessment, like ECG, vital signs, arterial blood gas, to assess the oxygenation of the patient, and to assess the acidosis and alkalosis of the status of the patient. We can use the pulse oximetry and carbon dioxide detector to know the patient's saturation and to know the patient's pulse rate. We have to assess the urine output through the urinary catheter, and we can apply gastric catheter unless contraindicated. These are adjuvants of the primary survey. Thank you for listening to me. We will again after this discussion with another video. Thank you for listening.